Hey guys, tonight we're talking about ketamine, the drug that was supposed to be a safe anesthetic and instead became the molecule that let people leave their bodies while doctors cut them open. Here's the thing nobody tells you. The same substance that saves lives in emergency rooms is the same one that turns nightclub bathrooms into portals to alternate dimensions. A horse tranquilizer became a battlefield miracle, then a party drug, then a depression cure, then an addiction epidemic, all from one lab accident in 1962. Before we continue, subscribe to the channel if you enjoy these stories. Write in the comments where you're watching from and what time it is. I always find it fascinating to see people from around the world united by one story. To understand how ketamine became the most schizophrenic drug in modern medicine, you first need to understand what problem it was supposed to solve. In the early 1960s, anesthesia was dangerous. Putting someone under meant gambling with their life because most anesthetics suppressed breathing. Patients needed ventilators, constant monitoring, and even then people died on operating tables from respiratory failure. The pharmaceutical industry was desperately searching for something gentler, something that wouldn't require a breathing tube and a prayer. Calvin Stevens wasn't trying to create a consciousness-altering molecule when he started working at Park Davis Laboratories in Detroit. The 37-year-old chemist had been tasked with finding an alternative to PCP, which worked as an anesthetic but caused patients to emerge from surgery psychotic and violent. His mandate was simple: keep the anesthetic properties, lose the insanity. Stevens synthesized hundreds of compounds, methodically tweaking molecular structures like a chef adjusting a recipe. Most were useless. Some were toxic. Compound CI-581 looked promising on paper. Similar structure to PCP, but with crucial differences in how it bound to receptors. The first test subjects were cats. Laboratory felines received injections of CI-581 and immediately did something that disturbed everyone in the room. They didn't fall asleep. Their eyes stayed open, wide and unblinking, staring at nothing. Their bodies went rigid but conscious, like taxidermied animals that forgot they were supposed to be dead. Researchers waved hands in front of feline faces and got no reaction. The cats seemed present but utterly absent, trapped in some space between wakefulness and unconsciousness that shouldn't exist. Stevens called it dissociative anesthesia. Consciousness separated from physical sensation like peeling apart layers of reality. The implications were staggering. Here was a drug that eliminated pain without eliminating awareness, at least not in the traditional sense. A cat under CI-581 could have surgery performed and wouldn't react, wouldn't feel, wouldn't remember. But it wasn't asleep either. Its brain waves showed activity. Its eyes tracked movement occasionally, as if something inside was still watching from very far away. The scientific team didn't know whether they'd created a medical breakthrough or a horror show. Human trials began in 1964 because ethical oversight was more suggestion than requirement back then. Park Davis researchers approached the Michigan prison system with a proposal. Let us test this experimental anesthetic on your inmates in exchange for reduced sentences. Dozens of prisoners volunteered, probably figuring any drug was better than their current situation. They were wrong. The first volunteer received an intramuscular injection of CI-581 and within minutes began describing something that sounded less like anesthesia and more like death. His body stopped responding to commands. His sense of self dissolved. He reported floating above the exam table, watching doctors work on a body he no longer inhabited. Other prisoners described tunnels of light, meetings with deceased relatives, conversations with geometric entities made of living mathematics. One man claimed he'd visited the moment of his own birth and watched himself being born from outside his mother's body. Another said he'd experienced his death, felt his consciousness expand beyond his skull and merge with something infinite. The medical team documented everything with clinical detachment. noting subjective experiences of depersonalization and derealization in their reports. What they'd actually done was give prisoners near-death experiences on demand. The disturbing part? The drug worked perfectly as an anesthetic. Prisoners could undergo minor surgical procedures without flinching, without pain, without any memory of the operation afterward. Their vital signs remained stable. They kept breathing on their own, no ventilator required. The dissociative experiences were side effects, not failures. Stevens had accidentally created exactly what Park Davis wanted, a safe anesthetic that didn't suppress respiration. The fact that it also catapulted consciousness into the cosmic void was just bonus weirdness that doctors would have to manage. By 1970, the FDA approved ketamine for medical use. The drug hit the market as Kettler, packaged in small glass vials with straightforward medical labeling that gave no hint of the existential chaos contained inside. Hospitals stocked it cautiously at first, unsure what to make of an anesthetic that left patients technically conscious. Anesthesiologists who tried it reported mixed results. Some patients emerged calmly, others thrashing and screaming about entities and voids and the death of self. The medical establishment called these emergence reactions and treated them as unfortunate complications rather than the drug's fundamental nature. Then Vietnam changed everything. The US. Military needed a battlefield anesthetic that medics could administer quickly without equipment. Morphine worked but suppressed breathing in high doses, killing wounded soldiers who might have survived. Traditional anesthetics required too much infrastructure. Tanks, tubes, monitoring devices that didn't exist in rice paddies. Ketamine was perfect. A single injection would sedate a screaming Marine with shrapnel in his gut, keep him breathing, and allow field surgeons to work. The drug became standard issue in combat medical kits by 1971. Medics loved it initially. Wounded soldiers could be stabilized and evacuated without the respiratory depression that killed so many in previous wars. Ketamine saved thousands of lives in situations where other anesthetics would have failed. But then medics started noticing something deeply strange. Some soldiers seemed disappointed to wake up, not because they wanted to die, but because the ketamine experience itself was so profound that returning to a shattered body in a Vietnam jungle felt like punishment. A few admitted they'd felt relief when they got hit because they knew the ketamine was coming. The military kept using it anyway because dead soldiers were worse than soldiers having cosmic experiences. Field hospitals administered thousands of doses to troops with missing limbs, gut wounds, burns that covered half their bodies. Young men barely out of high school had their consciousness ripped from their bodies, while surgeons performed emergency amputations. Some described it as the most peaceful moment of their entire tour. No fear, no pain, no awareness of the war. Just infinite space and the sense that everything might actually be okay, even as their physical forms were destroyed below them. Nobody tracked what happened to these soldiers long term. Nobody asked whether having your consciousness forcibly separated from your body during trauma might have psychological consequences. The military classified ketamine as a success and moved on. But some of those Vietnam veterans came home with a secret. They knew about a drug that could make reality optional, and it was legal, medical, and available if you knew where to look. By the mid-1970s, veterinarians were the primary source. Ketamine worked brilliantly on animals, especially horses, which is how it earned the horse tranquilizer nickname that would follow it for decades. Veterinary clinics stocked large quantities because farm animals required high doses. Security was minimal. A vet tech with light fingers could divert vials without anyone noticing until inventory came up short. The drug had barely any street value yet, so theft wasn't considered a serious risk. The first recreational users were predictable: medical professionals, chemistry students, psychonauts looking for new territories to explore. They started with low doses, carefully measuring out fractions of what would be used surgically. The effects at these levels were subtle, a floating sensation, mild visual distortions, a sense that reality had become slightly negotiable. Increase the dose, and things got weirder. Objects lost solidity. The boundary between self and environment became porous. Push further, and the world simply disappeared, replaced by abstract geometries and the overwhelming certainty that physical reality was just one option among infinite possibilities. The psychedelic community remained divided on ketamine. LSD devotees found it too dark, too dissociative, lacking the emotional warmth and visual beauty of classic psychedelics. Ketamine didn't show you a better version of reality. It showed you that reality itself was a construct your brain had been generating all along, and now the generator was malfunctioning. Some found this liberating, others found it terrifying. The drug developed a reputation as something serious, not a party substance, but a tool for people genuinely interested in consciousness research or willing to confront existential truths most humans spent their lives avoiding. John Lilly heard about ketamine in 1974 and recognized his next obsession immediately. The neuroscientist was already famous for his dolphin communication experiments and sensory deprivation research. He'd been searching for ways to explore consciousness without the visual noise and emotional content of LSD. Ketamine was perfect. Pure dissociation, consciousness stripped of sensory input and narrative structure. Lilly began injecting himself with increasing doses, sometimes multiple times per day, floating in his isolation tank in complete darkness, while the drug dissolved his sense of self. His experiences went beyond recreational. Lilly documented contact with entities he named ECHO, the Earth Coincidence Control Office, which he described as cosmic bureaucrats managing synchronicity and probability. These weren't hallucinations in the traditional sense because ketamine doesn't create visions like LSD does. Instead, it creates spaces, absences, voids, where something else can emerge. Lilly believed he was accessing genuine alternate dimensions, that ketamine was a technology for consciousness rather than a drug. His scientific colleagues thought he'd lost his mind. His writings became increasingly unhinged, mixing legitimate neuroscience with cosmic conspiracy theories. But Lilly's research spread through underground networks. His book sold quietly, passed between psychonauts and consciousness researchers who saw his work as either profound or a cautionary tale. Ketamine remained legal throughout the 1970s and 1980s because it never achieved the popularity of LSD or cocaine. The experience was too strange for mass appeal. Most people who tried it once decided that was enough. The dissociation felt too much like dying, too alienating, too far beyond human experience to be pleasurable. This kept it niche, which kept it legal, which kept it available for the people who understood its power. Emergency rooms continued using it on trauma patients. Pediatricians gave it to children before painful procedures, and veterinarians tranquilized animals with it daily. The drug remained medically essential and recreationally obscure, known only to a small community of explorers willing to chemically induce what mystics had spent lifetimes trying to achieve through meditation. Nobody imagined that 3 decades later, this strange dissociative molecule would become one of the most controversial drugs in modern psychiatry, simultaneously hailed as a miracle cure for depression and condemned as a new addiction epidemic. The foundation was laid. A battlefield anesthetic discovered by accident, tested on prisoners, deployed in a jungle war, and quietly adopted by consciousness explorers. Ketamine existed in medical practice and underground culture simultaneously, legal but mysterious, therapeutic, but potentially dangerous. The molecule that separated mind from body was waiting for the next chapter, when desperation would transform it from niche curiosity into mainstream treatment. The 1980s rave scene needed a new molecule and didn't know it yet. MDMA was still legal, LSD remained the standard consciousness alteration tool, and cocaine fueled the dance floors of every major city. Ketamine entered this landscape sideways, brought in by the strange overlap between medical access and underground chemistry. A British anesthesiologist attending an after-party in Manchester brought a vial from his hospital. He described it as completely different from anything the ravers had experienced. Not euphoric like MDMA, not visual like acid, but something that would make them question whether they'd ever actually existed at all. The first club users treated it like any other party drug and immediately regretted their assumptions. A standard recreational dose at a warehouse party in 1983 put 3 people in what would later be called K-holes, complete dissociative breaks where the music disappeared, the crowd vanished, and consciousness itself became negotiable. One user later described spending what felt like centuries as a geometric pattern before suddenly snapping back to reality on a grimy bathroom floor. Another claimed she'd become the building, experiencing the structural stress of supporting multiple floors of dancing humans. The third stopped attending raves entirely, convinced that physical reality was a shared hallucination, maintained by collective agreement. Word spread through the underground with mixed warnings. Ketamine wasn't fun in the traditional sense. It was confrontational, alien, possibly transformative if you survived the experience intact. The dose made all the difference. Small amounts created a pleasant floating sensation, a gentle removal from the intensity of club environments. Medium doses produced what users called wonky, stumbling, reality becoming elastic, depth perception vanishing so staircases became death traps. High doses deleted consciousness entirely, leaving bodies slumped in corners while minds travelled through spaces that had no physical correlate. The drug found its niche among a specific subset of experienced psychonauts who'd grown bored with conventional hallucinogens. These weren't casual users looking for a good time, but consciousness explorers treating their brains like laboratories. They gathered in small groups, carefully measured doses, and documented their experiences with the seriousness of Victorian naturalists cataloguing new species. What they discovered was a substance that didn't fit existing categories. Ketamine wasn't a psychedelic in the classic sense because it didn't amplify sensory input or emotional states. Instead, it subtracted them, peeling away layers of constructed reality until only something fundamental remained. Underground chemists took notice. Unlike LSD, which required complex synthesis that authorities monitored closely, ketamine was legally manufactured in massive quantities for medical use. Diversion became the primary supply method rather than synthesis. Veterinary clinics represented the easiest targets because they stocked large animal doses with minimal security. A single bottle of ketamine meant for sedating a horse contained enough material for dozens of human trips. Employees with access began supplementing their income by selling to networks that connected veterinary supply chains directly to rave culture. The phenomenon stayed contained for years because ketamine's effects created a natural filter. Most people who tried it once had no desire to repeat the experience. The dissociation felt too much like dying, too unsettling, too far removed from the social bonding that made other club drugs attractive. MDMA made you love everyone. Ketamine made you question whether everyone, including yourself, actually existed. This wasn't recreational in any recognizable sense. The drug became known as something serious people did alone or in very small trusted groups, not something you'd take in the middle of a crowded club unless you wanted to forget how to walk and potentially how to be human. But those who returned to it discovered something unexpected. Repeated ketamine experiences created a map of consciousness that became increasingly familiar. Users learned to navigate dissociative spaces the way sailors learn to read stars. They developed techniques for maintaining some thread of awareness even during high-dose experiences, like holding onto a rope while exploring underwater caves. A subculture emerged around these practices. Trip reports shared through early internet forums, guidelines for safe exploration, warnings about dosages that led to complete ego dissolution versus those that allowed for guided journeys. Terence McKenna, already famous for evangelizing psilocybin mushrooms, tried ketamine in 1987 and emerged disturbed. The ethnobotanist and psychedelic philosopher described it as showing the skeleton of consciousness stripped of human content. No plant intelligence, no visual poetry, just raw mechanism. He warned his followers that ketamine was dangerous precisely because it worked so well at dissolving the self. Unlike mushrooms or DMT, which McKenna believed revealed truths about nature and consciousness, ketamine simply revealed that consciousness was an emergent property that could be switched off like a light. This terrified him more than the alien geometries of DMT. McKenna continued using it anyway, drawn to its power even as he warned others about its coldness. The therapeutic potential remained completely unrecognized. Underground users in the late 1980s occasionally mentioned feeling better emotionally after ketamine sessions, but they attributed this to the intensity of the experience itself, the way confronting ego death might reset psychological patterns. Nobody imagined that the drug's mechanism of action had anything to do with depression treatment. Psychiatry was focused on serotonin and dopamine, building the entire SSRI revolution around these neurotransmitters. Ketamine worked through NMDA receptors, a completely different system that nobody associated with mood disorders. The connection would remain invisible for another decade. By 1990, ketamine had achieved a strange equilibrium. It remained legal for medical use but controlled enough that casual diversion was difficult. Anesthesiologists used it primarily in pediatrics and emergency medicine, where its respiratory safety made it uniquely valuable. Veterinarians relied on it for everything from cat spays to horse surgeries. The recreational user base stayed small and self-selecting. A few thousand people worldwide who understood the drug's nature and accepted its challenging effects. Law enforcement barely noticed because ketamine didn't fit their models of drug abuse. It produced no physical addiction, no crime waves, no overdose deaths. Users didn't become violent or erratic. They just occasionally became convinced that physical reality was optional. The rave scene of the early 1990s finally gave ketamine wider exposure. Warehouses in London, Berlin, and New York saw increasing use, particularly in chill-out rooms where the drug's dissociative effects complemented ambient music and dim lighting. Users would take small bumps throughout the night, maintaining a steady wonkiness that made the sensory overload of dance floors feel distant and manageable. The term Special K emerged around this time, borrowed from the breakfast cereal as either irony or marketing genius. Suddenly, ketamine had a brand name that sounded friendly rather than clinical. Club promoters began noticing a pattern. Ketamine users didn't dance. They sat or lay down, sometimes for hours, moving only occasionally and apparently at random. This created logistics problems in crowded venues where space was premium. More concerning were the users who would stand up after a dose, attempt to walk, and immediately collapse because their brains had forgotten how legs worked. Bouncers learned to recognize the distinctive stumble of someone on ketamine, the way they'd reach for walls that weren't there or try to climb stairs that had become abstract concepts rather than physical objects. Emergency room visits increased but remained relatively rare. The typical ketamine casualty wasn't overdosing in the traditional sense. The The drug's safety margin remained impressive compared to opioids or alcohol. Instead, ERs saw injuries from falling, confused users wandering into traffic, occasional aspiration from vomiting while dissociated and unable to protect their airways. Doctors treating these cases were often puzzled because the patients would test positive for a familiar anesthetic that shouldn't have been in their systems unless they'd recently had surgery. The disconnect between medical ketamine and recreational ketamine remained strong in the minds of healthcare providers. Underground chemists who'd been synthesizing other drugs began experimenting with ketamine production. The synthesis wasn't particularly difficult for anyone with organic chemistry training, though obtaining precursor chemicals attracted attention from authorities monitoring for PCP manufacture. Most recreational supply still came from diversion. Employees at pharmaceutical companies, veterinary clinics, hospitals and research facilities who understood they were sitting on a valuable product that nobody was carefully tracking. A vial of liquid ketamine purchased legally for $30 could be diluted, divided and sold for 10 times that amount on the club circuit. The British government classified ketamine as a controlled substance in 2006, responding to reports of increasing recreational use. This decision surprised medical professionals who relied on it as a safe pediatric anesthetic. Suddenly using ketamine in emergency rooms required additional paperwork and justification. Some doctors switched to alternatives rather than deal with the bureaucracy, which meant children with broken bones waited longer for pain relief because the safe option had become inconvenient. The unintended consequences of drug scheduling played out in hospital corridors where crying kids learned that policy responses to recreational drug use don't distinguish between abuse and legitimate medical need. The United States kept ketamine in Schedule 3, meaning it had accepted medical uses but moderate abuse potential. This classification allowed continued medical use without excessive restriction, but also meant the DEA monitored manufacturing and distribution. Doctors could prescribe it, though few did outside of surgical contexts because the dissociative effects seemed too unpredictable for outpatient treatment. The drug remained trapped in a paradox, too weird for mainstream medicine, too useful to ban completely, too strange to become truly popular recreationally. The internet changed everything about underground drug culture in the early 2000s. Forums dedicated to trip reports and harm reduction allowed ketamine users worldwide to share experiences, compare dosages, and develop collective knowledge about a substance that medical literature barely acknowledged existed outside of anesthesia. Users posted detailed descriptions of K-hole experiences, attempting to map consciousness states that had no official vocabulary. Terms emerged organically: the waiting room, the void, ego death, rebirth, entity contact, the cosmic giggle. A shared language developed for discussing experiences that couldn't be described in conventional terms. Harm reduction organizations began publishing ketamine safety information because ignoring the drug's recreational use wasn't preventing people from taking it. Guidelines appeared online explaining the difference between a manageable dose and one that would completely dissolve your sense of self. Users learned about bladder damage from chronic use, though this warning seemed abstract compared to the immediate weirdness of the high. The advice was pragmatic. If you're going to do this drug anyway, here's how to minimize the damage. Test your substances, use a scale, have a sitter present, don't operate machinery, avoid mixing with depressants, and for the love of everything, don't take it standing up. A small number of therapists began using ketamine off-label in underground practice. These weren't rogue doctors running pill mills, but legitimate psychologists and psychiatrists who'd witnessed the drug's effects on consciousness and saw therapeutic potential that official medicine was ignoring. They worked quietly, carefully, documenting sessions where patients would take measured doses and explore psychological material that conventional therapy couldn't access. These practitioners understood they were operating in a legal grey area, using an approved medical substance but for unapproved purposes, without FDA guidance, insurance coverage, or institutional support. The sessions produced remarkable results in some cases. Patients with treatment-resistant depression reported temporary relief. Trauma survivors accessed memories and emotions that had been locked away for decades. End-of-life patients confronted their mortality and emerged with reduced anxiety about death. But these were anecdotal case reports, not controlled studies. The plural of anecdote isn't data, and the medical establishment didn't care how many individual stories accumulated. Without double-blind trials and peer-reviewed publications, ketamine remained an anesthetic that some weirdos took at raves, and a few fringe therapists experimented with illegally. The molecule existed in 3 separate worlds by 2010: medical anesthesia, recreational club drug, and underground therapeutic tool. These worlds rarely intersected. Anesthesiologists didn't attend raves, ravers didn't read medical journals, and underground therapists kept their practices hidden from both communities. Ketamine's fragmented existence meant nobody had the complete picture of what the substance actually did or could do. Each group understood one facet while remaining ignorant of the others, but research was quietly advancing in academic laboratories. A few maverick scientists were asking questions that would soon blow apart every assumption about depression treatment, antidepressants, and the chemical basis of mood disorders. They were discovering that ketamine's NMDA receptor blockade triggered a cascade of neuroplastic changes, forcing the brain to rapidly grow new synaptic connections, essentially rewiring neural circuits within hours instead of weeks. This mechanism was completely different from every other antidepressant on the market. If the early results held up, they'd stumbled onto something revolutionary. The underground users, the rogue therapists, and the consciousness explorers had been right all along. They just didn't know why yet. Psychiatry in the late 1990s was failing spectacularly, and nobody wanted to admit it. Prozac had launched a decade earlier with promises of revolutionary mood treatment, spawning an entire generation of SSRIs that became billion-dollar blockbusters. The problem was simple and devastating. They barely worked better than placebo for mild to moderate depression, and millions of severely depressed patients showed no response whatsoever. Worse, the drugs required weeks to take effect, leaving suicidal patients in crisis with nothing but hope and supervision while waiting for serotonin reuptake inhibition to maybe, possibly, eventually help. A surgeon at Yale New Haven Hospital noticed something strange in 1994. Patients undergoing operations with ketamine anesthesia would sometimes mention feeling emotionally lighter in recovery, describing their depression as temporarily lifted even while dealing with surgical pain. The surgeon mentioned this to a psychiatry researcher named John Crystal, who filed the observation away as mildly interesting but probably meaningless. Anesthetics did all sorts of odd things to consciousness. Attributing specific mood effects to ketamine seemed like reading tea leaves. Crystal had more pressing research focused on glutamate and schizophrenia, pursuing the same NMDA receptor system that ketamine affected, but approaching it from the opposite direction. The connection assembled itself slowly across multiple research groups who weren't communicating. Scientists studying glutamate neurotransmission discovered that blocking NMDA receptors triggered something called BDNF, brain-derived neurotrophic factor, which forced rapid growth of new neural connections. Other researchers documented that chronic stress and depression physically damage synapses in the prefrontal cortex and hippocampus, shrinking these brain regions measurably. The antidepressant mechanism nobody was discussing involved not serotonin but neuroplasticity, the brain's ability to rewire itself by growing new connections between neurons. Crystal finally designed a small study in 2000 after reading reports from Russia where physicians had been using low-dose ketamine for various psychiatric conditions since the 1980s. The Russian literature was largely ignored by Western medicine because of language barriers and Cold War-era skepticism about Soviet science. But the reports were consistent. Brief ketamine treatments produced rapid improvements in depression that lasted days to weeks. Crystal recruited 17 patients with major depression who'd failed multiple antidepressant trials. These were people who'd tried everything: SSRIs, SNRIs, MAOEs, tricyclics, therapy, ECT in some cases, and remained miserably depressed despite years of treatment. The first infusion produced results that seemed impossible. Within 4 hours, more than 70% of patients showed significant improvement on depression rating scales. Several participants described it as a fog lifting, like someone had turned on lights in a room they'd been sitting in darkly for years. The effect wasn't gradual. It was sudden, dramatic, and completely unlike the slow titration of conventional antidepressants. One patient who'd been actively suicidal that morning reported no suicidal ideation by afternoon. The research team assumed they'd made measurement errors and rechecked everything. The numbers held. The mechanism was starting to make sense at the molecular level. Ketamine blocked NMDA receptors briefly, which paradoxically caused a surge of glutamate release downstream. This glutamate flood activated other receptors called AMPA, triggering massive BDNF release that forced dendritic spine growth, the tiny protrusions on neurons where synapses form. The brain was essentially forced to grow new wiring within hours. MRI studies would later show that a single ketamine infusion could reverse months or years of stress-induced brain atrophy in the prefrontal cortex, restoring lost volume and connectivity. The problem was duration. Effects lasted about a week on average, sometimes more, often less. Patients would return to depression as the newly formed synapses presumably degraded or as underlying neurochemical problems reasserted themselves. The research team experimented with repeated infusions and found that multiple doses could extend the antidepressant effects, but this raised obvious questions about long-term safety. Ketamine was still primarily known as an anesthetic and club drug. Proposing it as a maintenance psychiatric treatment seemed professionally risky. Publication of the initial results in 2006 barely registered outside of academic psychiatry. The study was small, uncontrolled for placebo effects, and proposed a mechanism that contradicted decades of serotonin hypothesis research that had made pharmaceutical companies incredibly wealthy. SSRIs generated tens of billions annually, suggesting that depression wasn't primarily about serotonin, but about synaptic connectivity and glutamate systems, threatened both scientific consensus and economic interests. Most psychiatrists ignored the findings, or dismissed them as interesting but clinically irrelevant. A few researchers took notice and began replication studies. Mount Sinai, the National Institute of Mental Health, and several European centres ran their own ketamine trials throughout the late 2000s. Results were remarkably consistent. Rapid antidepressant effects in 60-70% of treatment-resistant patients, with response times measured in hours rather than weeks. The effect was particularly dramatic in suicidal patients, where conventional treatment required hospitalization and constant monitoring while waiting for medications to work. Ketamine could potentially save lives by immediately reducing suicide risk, while longer-term treatments took effect. By 2010, academic medical centers were quietly offering ketamine infusions to desperate patients who'd exhausted every other option. These weren't official programs, but individual psychiatrists operating under off-label prescribing authority, using a drug approved for anesthesia to treat a psychiatric condition. Insurance wouldn't cover it because ketamine wasn't FDA approved for depression. Patients paid out of pocket, typically $400 to $800 per infusion, for a treatment that would probably help but only temporarily, requiring repeated sessions to maintain effects. The economics created immediate inequality. Wealthy patients could afford repeated infusions every week or two indefinitely. Everyone else got nothing because mainstream psychiatry still wasn't prescribing ketamine despite mounting evidence. Academic publications remained cautious, emphasizing that more research was needed, that long-term effects were unknown, that abuse potential remained a concern. Meanwhile, severely depressed people who could afford treatment were experiencing relief that conventional medicine had failed to provide after years of trying. Celebrities discovered it first because they always do. Silicon Valley executives heard about it through networks of concierge physicians who catered to the wealthy and early adopted any treatment that showed promise. Word spread through exclusive channels, personal referrals, private psychiatrists, medical tourism to clinics in Mexico or the Caribbean that offered ketamine therapy outside US regulatory frameworks. The treatment developed a reputation as something the elite accessed while everyone else suffered on SSRIs that barely worked. A handful of entrepreneurial physicians recognized the business opportunity and opened ketamine clinics specifically focused on depression treatment. These weren't hospitals or traditional psychiatric practices, but specialized facilities designed around ketamine infusion protocols. Patients would arrive, receive an IV infusion over 40 minutes while reclining in comfortable chairs with eye shades and music, then rest in recovery before going home. The clinical model was simple and profitable, minimal overhead, high out-of-pocket payments, and patients desperate for relief who'd tried everything else. The first wave of ketamine clinics maintained high standards. Many were founded by academic psychiatrists who'd seen the research and believed in the treatment's potential. They required comprehensive psychiatric evaluations before accepting patients, monitored vital signs carefully during infusions, and provided integration therapy to help patients process the dissociative experiences. These early clinics viewed ketamine as a serious medical intervention, requiring appropriate caution and expertise. But regulatory oversight was minimal because ketamine remained a legal Schedule III medication. Any physician with a DEA license could prescribe it for any condition. Off-label use was entirely legal. This meant psychiatrists, anesthesiologists, family doctors, and even chiropractors with medical degrees could legally open ketamine clinics without specific training in psychiatric care or addiction medicine. Quality varied wildly as the number of clinics exploded from dozens to hundreds between 2012 and 2015. Stories of miraculous recoveries multiplied across patient communities. A woman who'd been depressed for 20 years tried ketamine after her 6th suicide attempt and felt normal for the first time since adolescence. A combat veteran with PTSD and severe depression stopped having nightmares after 3 infusions. A corporate lawyer with treatment-resistant depression maintained remission with weekly ketamine sessions after failing 8 different antidepressants. These testimonials spread through social media and online forums, creating demand that far exceeded the supply of reputable clinics. Research continued advancing understanding of the neurological mechanisms. Studies using PET scans showed that ketamine increased metabolic activity in the prefrontal cortex within minutes, lighting up brain regions that depression had darkened. Other research demonstrated that the drug's effects required protein synthesis. If you blocked the brain's ability to manufacture new proteins, ketamine's antidepressant effect disappeared. This confirmed that the mood improvements weren't just dissociative distraction, but genuine neuroplastic changes that took time and cellular machinery to implement. The duration problem remained unsolved. Most patients needed repeated infusions to maintain benefits, creating concerns about long-term exposure to a dissociative anesthetic. Nobody knew what happened to brains that received ketamine weekly or bi-weekly for months or years. The research establishing ketamine's safety profile came from single-use surgical anesthesia, not chronic repeated dosing in psychiatric patients. Anesthesiologists used it once and moved on. Psychiatrists were proposing indefinite maintenance treatment, a completely different exposure pattern with unknown consequences. Some clinics began experimenting with higher doses and more frequent sessions based on patient demand rather than clinical evidence. If standard protocols produced 1 week of relief, maybe higher doses would extend it to 2 weeks. If patients felt better at higher doses, why not give them what they requested? This logic ignored the dose-dependent nature of side effects and abuse potential. Patients chasing relief became unwitting test subjects in uncontrolled experiments conducted by physicians who were sometimes more entrepreneur than clinician. The psychiatric establishment remained divided. Conservative academic departments viewed ketamine as unproven, potentially dangerous, and too closely associated with recreational drug culture to be respectable medicine. Progressive clinicians argued that withholding an effective treatment from suffering patients while waiting for perfect evidence was unethical. The debate played out in journal articles and conference presentations, while desperate patients made decisions based on incomplete information and financial ability rather than clinical appropriateness. By 2015, an estimated 60 to 80 ketamine clinics operated across the United States alone, with more opening monthly. The treatment had achieved a critical mass where mainstream media began covering it. Major magazines ran features on the miracle depression cure, describing ketamine as a revolutionary approach that defied conventional psychiatric wisdom. These articles rarely mentioned the temporary effects, the lack of long-term safety data, or the financial barriers preventing most patients from accessing treatment. The narrative simplified to, depression has a cure, and it's been an anesthetic all along. The truth was vastly more complicated. Ketamine worked remarkably well for some patients, moderately for others, and not at all for a significant minority. Effects varied based on factors nobody fully understood: genetics, depression subtype, trauma history, concurrent medications, and probably dozens of other variables that research hadn't identified yet. The drug wasn't a cure, but a powerful tool that could provide temporary relief, potentially allowing other treatments or life changes to take hold. Calling it a miracle or a cure set unrealistic expectations that would eventually crash against the reality of chronic illness requiring ongoing treatment. Underground therapeutic use and mainstream medical treatment had finally converged. The same molecule that psychonauts had been exploring in isolation tanks and that ravers took in club bathrooms was now being administered in medical offices with heart rate monitors and liability insurance. Ketamine had crossed over from counterculture to clinical medicine, bringing all its complexity, promise, and danger with it. The next phase would determine whether this convergence represented medical progress or a catastrophic failure of regulatory oversight. The answer was probably both. Johnson & Johnson's executives watched the ketamine clinic boom with something between envy and rage. A generic drug they couldn't patent was generating hundreds of millions in off-label psychiatric use, and they weren't seeing a penny. The pharmaceutical giant had a department specifically tasked with finding profitable angles on existing molecules, and ketamine presented a perfect opportunity wrapped in a legal problem. The drug itself was too old for patent protection. Any company could manufacture generic ketamine freely. But molecular manipulation could create a patentable variation, and depression treatment represented a market worth $20 billion annually. The solution arrived through stereochemistry, the science of molecular mirror images. Ketamine existed as a mixture of two forms, called R-ketamine and S-ketamine that were identical in composition but opposite in three-dimensional structure like left and right hands. Most pharmaceutical ketamine contained both forms in equal mixture. Johnson & Johnson's researchers isolated S-ketamine alone, creating a purified version they could claim as novel despite being chemically almost identical to the original. The strategy was brilliant and legally cynical. Take half of an existing molecule, call it innovative, and charge whatever the market would bear. Clinical trials for esketamine began in 2013 with Johnson & Johnson, funding that dwarfed all previous ketamine research combined. The company enrolled over 1,600 patients across multiple studies, comparing their nasal spray formulation against placebo in treatment-resistant depression. Results showed modest superiority over placebo, about 20% better response rates, which was enough for FDA approval consideration, but hardly the miraculous outcomes that generic ketamine infusion studies had reported. Critics pointed out that nasal absorption produced more variable blood levels than IV infusion, potentially explaining the weaker effects. Johnson & Johnson countered that convenience and self-administration justified the different delivery method. The FDA approval process moved with unusual speed. Typically, getting a new psychiatric medication approved required years of review, multiple rounds of data requests, and extensive safety evaluations. Esketamine received Breakthrough Therapy designation in 2013, a category meant for drugs treating serious conditions where preliminary evidence suggested substantial improvement over existing treatments. This designation allowed expedited review despite the fact that generic ketamine already existed and worked. The FDA was essentially fast-tracking approval for a patented version of a drug that had been available for decades. March 2019 brought FDA approval for Spravato, the brand name Johnson & Johnson chose for esketamine nasal spray. The drug was indicated specifically for treatment-resistant depression in conjunction with an oral antidepressant. The approval came with restrictions unprecedented for an antidepressant. Patients had to take it at certified medical facilities under direct observation for 2 hours post-administration because of dissociation and potential abuse. Insurance companies would only cover treatment at registered clinics, where medical staff monitored patients during and after dosing. The price was predatory even by pharmaceutical industry standards. Johnson & Johnson set the cost at $590 to $880 per session, depending on dosage, with treatment protocols requiring twice-weekly dosing for the first month, then weekly, then potentially less frequently. A month of treatment could cost $4,700 to $7,080 before any potential insurance coverage. Annual cost for maintenance treatment could exceed $30,000. This was roughly 5 to 10 times more expensive than generic ketamine infusions, which themselves were already financially prohibitive for most patients. The marketing campaign was sophisticated and aggressive. Johnson & Johnson portrayed Spravato as a revolutionary breakthrough, rarely mentioning that the active ingredient was ketamine, which had been treating depression for years. Patient advocacy groups received funding to promote awareness of treatment-resistant depression and the new options available. Medical journals published supplement issues about rapid-acting antidepressants, sponsored by Johnson & Johnson, that positioned esketamine as the culmination of decades of glutamate research. The messaging was clear. This was legitimate pharmaceutical medicine, not the sketchy off-label use of a party drug. Physicians who'd been offering generic ketamine infusions found themselves in an awkward position. Insurance companies began questioning why doctors prescribed IV ketamine when an FDA-approved nasal spray existed. Some insurers refused to cover generic ketamine infusions, while demanding patients try Spravato first, despite the higher cost. The logic was bureaucratic absurdity. pay more for a branded version that worked less consistently than the generic treatment, all because regulatory approval provided legal cover for insurance companies nervous about off-label prescribing. Generic ketamine clinics fought back by emphasizing their superior efficacy and lower cost. Multiple studies confirmed that IV infusions produced more reliable antidepressant effects than nasal spray because blood levels could be precisely controlled. The infusion model also allowed for integration therapy during the dissociative experience, with therapists helping patients process the ketamine state in real time. Nasal spray patients sat in clinic offices waiting for side effects to resolve, getting treatment but not therapy. The approaches were fundamentally different despite using the same molecule. Johnson & Johnson's regulatory capture had created a bizarre two-tier market. Wealthy patients or those with excellent insurance could access Spravato through certified clinics and receive partial reimbursement. Everyone else had three options: pay cash for generic ketamine infusions, pay cash for Spravato without insurance, or go untreated. The FDA approval hadn't expanded access to ketamine treatment. It had created a branded monopoly that cost more and potentially worked worse than the existing alternative. The number of ketamine clinics exploded regardless. Physicians who'd been cautious about off-label prescribing suddenly felt emboldened because FDA approval of esketamine validated ketamine's antidepressant effects. If the FDA accepted that ketamine derivatives treated depression, then prescribing the original molecule off-label seemed less legally risky. Over 500 clinics operated in the United States by 2020, offering various ketamine formulations: IV infusions, intramuscular injections, nasal sprays, sublingual lozenges, even oral capsules. Quality control remained essentially non-existent. Some clinics were run by experienced psychiatrists who followed research protocols carefully. Others were fronts for physicians who saw a cash opportunity and provided minimal oversight. Patients reported wildly different experiences depending on where they went. Some clinics offered therapeutic support and careful monitoring. Others felt like pill mills where you paid money, got drugged, and left with little medical attention. The lack of standardization meant outcomes varied dramatically based on factors unrelated to the drug itself. Telemedicine companies recognized the next frontier. Why require patients to visit clinics when medication could be prescribed remotely and mailed directly? Several startups launched in 2018 and 2019, offering ketamine prescriptions after brief video consultations. Patients would complete online questionnaires, speak with a doctor for 10 to 15 minutes via video call, and receive prescriptions for ketamine troche, sublingual lozenges that dissolved slowly in the mouth. The entire process took less than an hour, and medication arrived at patients' homes within days. The telemedicine model eliminated most safety oversight. Patients took ketamine alone in their homes without medical monitoring, vital sign checks, or supervision. Some companies provided integration therapy sessions via video, but many offered only the prescription with minimal follow-up. Dosing protocols came from the company's internal algorithms rather than individualized medical judgment. The approach prioritized convenience and profit over careful treatment, essentially turning prescription ketamine into a mail-order service. COVID-19 accelerated everything. The pandemic forced psychiatry into telemedicine practically overnight, and regulations that had restricted controlled substance prescribing via telehealth were temporarily lifted. Ketamine telemedicine companies saw enrollment spike as isolated, anxious, depressed people sought treatment while stuck at home. The DEA's emergency rules allowed prescribing Schedule III medications after video consultations, meaning patients could legally obtain ketamine without ever meeting their physician in person. The temporary policies created a parallel distribution system completely divorced from the clinic-based model that had dominated ketamine treatment. Patient communities online became essential information sources as medical guidance remained inconsistent. Reddit forums and Facebook groups dedicated to ketamine therapy accumulated thousands of members sharing experiences, comparing clinics, discussing dosing strategies, and warning about side effects. These communities operated as informal regulatory bodies, calling out clinics that provided inadequate care and recommending providers who took treatment seriously. Patients were essentially regulating an industry that official medicine had failed to standardize. The underground and mainstream markets began blurring. Some patients would start with legitimate prescriptions, then supplement with veterinary ketamine or darknet purchases when medical treatment became too expensive. Others would begin recreationally, discover antidepressant effects, and seek medical oversight. The distinction between medical and recreational use became increasingly meaningless. The same molecule was simultaneously medicine, party drug, and something in between depending on context, dosing, and intention. Research continued revealing complexity that marketing ignored. Some studies suggested that R-ketamine, the stereoisomer Johnson & Johnson discarded, might actually produce longer-lasting antidepressant effects with less dissociation than S-ketamine. Other research indicated that the dissociative experience itself was essential for therapeutic benefits, not a side effect to minimize. The metabolites ketamine broke down into showed their own antidepressant properties, suggesting the drug triggered cascading effects beyond simple NMDA blockade. The more scientists learned, the less clear it became which version of ketamine was optimal for depression treatment. By 2022, an estimated 500,000 Americans were receiving some form of ketamine treatment for depression, anxiety, PTSD, or other psychiatric conditions. The number was impossible to verify because much of the prescribing happened off-label through cash-pay clinics that didn't report to central databases. Johnson & Johnson's Spravato accounted for perhaps 50,000 patients, a tiny fraction of the total market but generating hundreds of millions in revenue because of the premium pricing. Generic ketamine dominated through sheer economics, despite lacking FDA approval for depression. The medical establishment had created an accidental natural experiment in drug distribution. Multiple formulations, delivery methods, dosing protocols, and treatment models all existed simultaneously, with minimal standardization or quality control. Patients were navigating this chaos themselves, making treatment decisions based on cost, availability, anecdotal reports, and desperation rather than clinical evidence or medical guidance. The system had produced access without structure, availability without safety, and treatment without understanding. Addiction specialists began warning that the enthusiasm was outpacing the evidence. Long-term ketamine use was creating dependency in a subset of patients who couldn't distinguish between therapeutic need and psychological addiction. The dissociative effects were becoming the point rather than a side effect tolerated for antidepressant benefits. Some patients were escalating doses on their own, seeking deeper dissociative experiences and convincing themselves this was therapeutic exploration rather than drug-seeking behavior. The warning signs were obvious to anyone who'd studied substance abuse patterns, but the momentum was unstoppable. Too many patients reported genuine benefit, too many clinics were making money, too much media attention celebrated ketamine as a breakthrough. The concerns about addiction and long-term harm got drowned out by testimonials from people whose lives had improved dramatically. The question wasn't whether ketamine helped some people, it clearly did, but whether medical infrastructure could deliver it responsibly to those who needed it while preventing abuse by those who didn't. The evidence suggested that infrastructure didn't exist and nobody was building it. Johnson & Johnson expanded its marketing despite mediocre effectiveness data. The company's revenue projections showed Spravato becoming a multi-billion-dollar product if they could capture even a fraction of the depression treatment market. They lobbied for expanded indications, seeking FDA approval for conditions beyond treatment-resistant depression. The business model required turning ketamine from a last resort option into a mainstream treatment, prescribing it earlier in the treatment sequence rather than only after everything else failed. The pharmaceutical industry's entry had legitimized ketamine treatment and simultaneously corrupted it. FDA approval provided regulatory cover and insurance reimbursement, while introducing profit motives that distorted medical decision-making. The drug that underground therapists had carefully explored in the 1990s and academic psychiatrists had researched in the 2000s was now a commercial product marketed aggressively with inflated claims and inadequate safety monitoring. Medicine and capitalism had collided, producing access for some and exploitation of many. The collision was about to get much worse. The first addiction cases appeared so gradually that nobody recognized the pattern until it was everywhere. A tech executive in San Francisco started ketamine infusions in 2017 for treatment-resistant depression after 2 suicide attempts. 6 sessions produced remarkable improvement. She returned to work, reconnected with friends, felt human again for the first time in years. The clinic recommended maintenance infusions every 3 weeks. She complied initially, then noticed that relief began fading after 2 weeks. She requested weekly sessions. The clinic agreed because the patient seemed stable and functional, and weekly dosing remained within reasonable medical practice even if research hadn't established optimal frequency. Within 8 months she was receiving infusions twice weekly, convincing her psychiatrist that her depression was severe enough to warrant aggressive treatment. The truth was more complicated. The antidepressant effect hadn't diminished, but she'd become psychologically dependent on the dissociative experience itself, the floating sensation, the ego dissolution, the temporary escape from being a person with responsibilities and problems. These had become more important than mood improvement. She was chasing the K-hole under the guise of medical treatment, and her doctor either didn't notice or didn't care because she paid cash and never missed appointments. By 2019, she was supplementing prescribed infusions with veterinary ketamine purchased from darknet markets. The medical ketamine kept her psychiatrist satisfied, while the veterinary supply let her dose at home on nights when anxiety or boredom or simple craving became unbearable. She told herself this was harm reduction, medical-grade substance from a reliable source, carefully measured doses, no mixing with other drugs. The rationalization ignored that she was using ketamine multiple times per week in increasing amounts while her life slowly disintegrated around her. Bladder problems began after 18 months of heavy use. Urinating became painful, then urgent, then constant. She'd need to urinate every 30 minutes, producing only drops but feeling desperate fullness. The pain was distinctive. A burning, aching sensation concentrated in the lower pelvis that worsened with bladder filling. She researched symptoms online and found descriptions of ketamine-induced cystitis, a condition documented in chronic users where the drug literally destroys the bladder lining. The mechanism involved toxic metabolites concentrating in urine and corroding tissue from the inside. Medical examination revealed severe damage. Cystoscopy showed her bladder wall inflamed and ulcerated, the tissue appearing burned and friable. The urologist asked about ketamine use. She admitted to prescribed infusions but lied about frequency and neglected to mention the veterinary supply. The doctor recommended stopping ketamine immediately and starting bladder-protective medications, warning that continued use could require surgical intervention, bladder augmentation, or complete removal with urinary diversion through an external bag. She was 34 years old and facing the possibility of permanent disability from a drug her psychiatrist had prescribed as antidepressant treatment. She stopped for 3 weeks. The bladder pain improved marginally, but depression returned with crushing intensity, compounded by the psychological void left by ketamine's absence. The drug had become her primary coping mechanism for stress, anxiety, boredom, and existence itself. Without it, everything felt intolerable. She resumed using at lower doses, promising herself she'd keep it under control this time. The control lasted 2 months before she was back to near daily use, bladder screaming in protest, caught between the need to stop and the inability to face life without chemical dissociation. Her case wasn't unique. Emergency departments across major cities began seeing ketamine bladder cases with increasing frequency after 2018. Young professionals, mostly, who'd started with legitimate prescriptions and escalated into dependence. The presentation was consistent: severe urinary symptoms, chronic pelvic pain, reduced bladder capacity sometimes down to less than 100 milliliters when normal capacity exceeded 400. Some patients required bladder removal and reconstruction using intestinal tissue. Others learned to self-catheterize multiple times daily to empty bladders that no longer functioned properly. A prescription antidepressant had led them to permanent urological disability. Cognitive effects emerged more subtly. Heavy ketamine users began reporting memory problems, difficulty forming new memories, gaps in existing memories, confusion about temporal sequence. The dissociative experiences themselves created memory impairment because ketamine disrupted the hippocampus's ability to consolidate short-term memories into long-term storage. Chronic users would lose hours or days knowing they'd done things but unable to recall specifics. Some described it as living in permanent present tense, where past and future blurred into irrelevance. Brain imaging studies on chronic users showed concerning changes. MRI scans revealed reduced grey matter in frontal and temporal cortices, the brain regions responsible for executive function, decision-making, and emotional regulation. PET scans demonstrated altered glucose metabolism patterns similar to those seen in other forms of substance abuse. The neuroplasticity that made ketamine therapeutic in acute doses apparently became neurotoxic with chronic exposure. The drug that forced rapid synapse growth in depressed brains might be damaging healthy neural tissue when used repeatedly over months or years. Online communities dedicated to ketamine therapy began splitting into factions. One group consisted of patients using the drug responsibly under medical supervision, typically monthly or bi-weekly infusions for genuine treatment-resistant conditions. They followed research protocols, attended therapy, and treated ketamine as serious medicine. The other group had crossed into dependency, using daily or near daily, sourcing supplies from multiple providers or illegal markets, and constructing elaborate justifications for why their usage was medical rather than addictive. The dependent users developed their own vocabulary and culture. They discussed sourcing strategies openly, which telemedicine companies had lax prescribing standards, which veterinarians had poor inventory control, how to synthesize ketamine from precursor chemicals available online. They shared techniques for managing tolerance by rotating between different routes of administration or cycling on and off to reset receptors. The discussions had the veneer of harm reduction, but functioned as enabling communities where addiction was normalized and reframed as therapeutic exploration. Some users began admitting they couldn't stop even when they wanted to. The psychological withdrawal wasn't physical agony like opioid cessation, but it was its own kind of hell, a creeping sense that reality itself was intolerable without chemical mediation. One user described it as suddenly being trapped inside their own consciousness without an escape hatch, forced to be fully present in a life that felt meaningless and overwhelming. Another compared it to losing a best friend who'd always been available to make everything okay temporarily. The dependence was emotional and existential rather than physiological, which made it harder to recognize and impossible to treat with standard addiction protocols. Ketamine's addiction profile confused medical professionals because it didn't fit established patterns. The drug produced no classic withdrawal syndrome, no tremors, no sweating, no vomiting or seizures. Users could stop abruptly without medical danger, but many couldn't stop at all because the psychological craving was overwhelming. They'd managed to develop a pure psychological addiction to a dissociative anesthetic, something the medical literature barely acknowledged was possible. Addiction specialists trained on opioids and alcohol didn't know how to approach treatment for people dependent on floating through the cosmic void twice a week. Clinics that had proliferated to meet demand now faced ethical dilemmas they weren't equipped to handle. Some patients clearly needed ongoing ketamine treatment. Their depression was severe, they'd tried everything else, and regular infusions kept them stable and functional. Other patients were obviously abusing the service, escalating frequency, showing signs of addiction, and lying about symptoms to justify more sessions. Distinguishing between legitimate medical need and drug-seeking behavior required expertise most clinics didn't possess. The profit motive complicated everything because turning away, paying customers meant losing revenue. A few clinics implemented safeguards. They required minimum time intervals between infusions, set maximum annual dose limits, mandated concurrent therapy, and screened for abuse patterns. These responsible providers saw themselves as gatekeepers protecting both patients and ketamine's medical legitimacy. But other clinics operated as de facto pill mills, accepting anyone who paid and prescribing whatever frequency patients requested. The lack of regulatory oversight meant both models existed simultaneously, and patients who got refused treatment at careful clinics simply went elsewhere. Telemedicine companies faced the worst incentive structures. Their business models depended on patient volume and subscription revenue from ongoing prescriptions. Cutting off patients who showed addiction signs meant losing income. Most companies chose profit over ethics, continuing to prescribe to users who were clearly dependent. Some implemented token safety measures like monthly check-ins or dose caps, but enforcement was minimal. Patients learned to say the right things during video consultations, emphasizing depression symptoms while downplaying dissociative effects and frequency of use. The medical community began publishing case reports documenting ketamine addiction. A 2020 paper described a patient who'd escalated from weekly infusions to daily self-administration within 2 years, eventually using 10 grams per week, enough to anesthetize a horse. She'd developed severe bladder damage, cognitive impairment, and complete inability to function without the drug. Treatment required psychiatric hospitalization, but standard addiction protocols didn't work because ketamine produced no physical withdrawal to manage. She left the hospital after 2 weeks and resumed using immediately because nobody could provide an alternative coping mechanism for the psychological void ketamine had filled. Another case report documented a physician who'd started prescribing ketamine to himself for depression and ended up using intravenously multiple times daily. His medical license allowed him to order pharmaceutical-grade ketamine directly, eliminating supply constraints. He maintained his medical practice for 18 months while severely addicted, seeing patients during the day and dissociating at night. Colleagues noticed cognitive decline. He'd forget patient information, lose track of conversations, make minor prescribing errors. His eventual arrest for controlled substance diversion revealed the extent of his addiction. He'd diverted over 200 grams of ketamine in a single year. The addiction potential created a paradox that nobody could resolve. Ketamine genuinely helped many patients with treatment-resistant depression. Denying them access caused suffering and potentially prevented suicides. but unrestricted access enabled addiction in vulnerable individuals who couldn't use the drug responsibly. The middle ground required robust screening, careful monitoring, and limiting prescribing to qualified psychiatrists with addiction expertise. That infrastructure didn't exist and wouldn't be built because the cash-pay ketamine industry operated outside traditional medical systems with minimal regulation. Families began dealing with addicted relatives who insisted their ketamine use was medical treatment. Parents watched adult children deteriorate, unable to work, socially isolated, using ketamine daily while claiming they needed it for depression. Spouses filed for divorce after partners chose ketamine over relationships, spending thousands monthly on clinics and veterinary suppliers. The addicted users rejected any suggestion they had a problem because their usage had started medically, progressed gradually, and looked nothing like stereotypical addiction to illegal drugs. Support groups for families affected by ketamine addiction formed online because traditional addiction resources didn't address dissociative anesthetics. These communities shared stories that followed predictable patterns: initial improvement from prescribed treatment, gradual escalation in frequency, personality changes as the user became emotionally flat and cognitively impaired, financial problems from expensive clinic fees or illegal purchases, physical complications from bladder damage or cognitive decline, and complete denial that anything was wrong because the addiction wore the mask of medical treatment. Treatment centers specializing in ketamine addiction began appearing in 2021, recognizing an unmet need. These facilities offered residential programs focused on addressing psychological dependence through intensive therapy, building coping skills for emotional regulation, and treating underlying conditions that ketamine had masked rather than cured. Success rates were modest because patients arrived with dual challenges: treating the original depression or trauma that had prompted ketamine use while breaking dependence on the drug that had become their primary coping mechanism. The most devastating cases involved users who developed tolerance requiring ever-increasing doses to achieve dissociative effects. Some were using amounts that would anesthetize small animals, administering the drug multiple times daily, maintaining a constant state of partial dissociation. They functioned minimally, could drive cars, hold basic conversations, perform routine tasks, but were essentially absent from their own lives. The ketamine had become a chemical escape hatch they used continuously, choosing dissociation over presence because their baseline consciousness had become unbearable. Research began documenting what everyone involved in ketamine treatment had suspected. A significant minority of patients transitioned from medical use to addiction, with estimates ranging from 10% to 30% depending on how dependence was defined. The percentage increased dramatically with certain risk factors: history of substance abuse, trauma, personality disorders, or using ketamine specifically for its dissociative effects, rather than tolerating those effects to obtain mood benefits. The medical community had created an iatrogenic addiction epidemic by prescribing a dissociative anesthetic to emotionally vulnerable people without adequate safeguards. The situation revealed something disturbing about modern psychiatric treatment. Ketamine's rapid adoption, despite minimal long-term safety data, showed how desperate both patients and doctors were for anything that worked better than SSRIs. The medical establishment had spent 30 years promoting antidepressants that barely outperformed placebo, creating a population of treatment-resistant patients who tried everything and still suffered. When something actually worked, even something with obvious addiction potential, the enthusiasm overrode caution. Medicine had been so focused on whether ketamine could treat depression that it failed to adequately consider whether it should be widely prescribed for that purpose. By 2023, the addiction cases had become too numerous to ignore. Medical journals published editorials warning about unrestricted ketamine prescribing. Addiction specialists called for tighter regulation and mandatory training for prescribers. Patient advocacy groups demanded better screening and monitoring, but the damage was done. Hundreds of thousands of people were using ketamine regularly, some therapeutically, others addictively, many in the grey zone between legitimate treatment and dependence. The infrastructure for distinguishing between these groups and intervening appropriately didn't exist. The molecule that started as a battlefield anesthetic had become a psychiatric medication, with an addiction profile nobody fully understood and a treatment model nobody could regulate effectively. Every day brought new patients hoping ketamine would save them from depression, and new victims discovering it had trapped them in a different kind of suffering. Ketamine became a political Rorschach test in 2021, revealing more about the observer than the observed. Wellness influencers on Instagram posted aesthetically curated images of IV bags and eye masks, describing ketamine therapy as part of their self-care routine, alongside meditation retreats and adaptogenic supplements. The messaging was relentlessly positive. Brave pioneers exploring consciousness, breaking stigma around mental health treatment, finding healing through innovative medicine. These posts accumulated thousands of likes and comments from followers who saw ketamine as empowerment rather than a dissociative anesthetic with abuse potential. Conservative media discovered ketamine through a different lens entirely. Fox News ran segments portraying it as liberal elites getting legally high under the guise of therapy, comparing it to the opioid epidemic's early stages when pharmaceutical marketing normalized addiction. The coverage emphasized ketamine's origins as a club drug, showing footage of party culture while warning that psychiatry was medicalizing recreational substances. The argument resonated with audiences already skeptical of psychiatric medication and suspicious that loosening drug restrictions was disguised social engineering. The psychedelic advocacy movement adopted ketamine as proof of concept for their broader agenda. Organizations pushing for MDMA and psilocybin legalization pointed to ketamine's therapeutic success as evidence that consciousness-altering substances could be legitimate medicine. If a dissociative anesthetic that people took at raves could treat depression, why not mushrooms or ecstasy? The logic was strategically sound but scientifically questionable. Ketamine's effectiveness didn't automatically validate other psychedelics, each of which had distinct mechanisms and risks requiring independent evaluation. Academic psychiatrists split into hostile camps over ketamine's role in treatment algorithms. Progressive clinicians argue that decades of failed SSRI treatment justified aggressive adoption of rapid-acting alternatives, even with incomplete safety data. They emphasized patient suffering and the ethical imperative to provide relief when conventional approaches had failed. Conservative psychiatrists countered that enthusiasm was outpacing evidence, warning that widespread prescribing without long-term outcome studies was reckless experimentation on vulnerable populations. The debates grew heated at conferences, with some researchers refusing to share panels with opponents. The FDA found itself trapped between political pressures pulling in opposite directions. Mental health advocates demanded expanded access to ketamine treatment, arguing that regulatory caution was condemning patients to continued suffering. Addiction specialists and conservative medical organizations pushed for tighter restrictions, citing mounting evidence of dependence and abuse. The agency's compromise satisfied nobody, maintaining ketamine's Schedule III status, while issuing warnings about proliferating clinics without actually shutting any down or establishing mandatory prescribing standards. Congress held hearings in late 2022 focusing on ketamine prescribing practices and the regulatory vacuum enabling questionable clinics. Democratic legislators emphasized success stories, patients whose lives have been saved by ketamine after exhausting conventional treatments. Republican members highlighted addiction cases and questioned why the DEA wasn't enforcing existing controlled substance regulations more aggressively. the testimonies presented incompatible realities. Ketamine was simultaneously a miracle cure and a looming public health disaster depending on which witnesses spoke. The criminal justice angle complicated everything further. Law enforcement agencies reported increasing ketamine use as a date rape drug because it produced compliance, amnesia, and inability to resist while keeping victims conscious. The same properties that made it useful for battlefield medicine, maintaining consciousness while eliminating pain perception, made it valuable for sexual predators. Victims would have fragmented memories of assault, knowing something happened but unable to provide coherent accounts or identify perpetrators. Toxicology screens often missed ketamine because it metabolized quickly and wasn't part of standard drug panels. Police departments began finding ketamine at crime scenes unrelated to sexual assault. Robberies where victims described being conscious but unable to move. Home invasions where residents watched powerlessly as their houses were ransacked. The drug had entered criminal toolkits alongside Rohypnol and GHB, valued for its ability to incapacitate without killing. Some law enforcement officials called for moving ketamine to Schedule II with stricter controls, but medical organizations resisted fiercely, arguing that tighter restrictions would limit legitimate therapeutic use and harm patients. Veterinarians reported increasing thefts from clinics that stocked ketamine for animal procedures. The break-ins followed predictable patterns: forced entry through rear doors, targeted theft of controlled substances with ketamine specifically targeted, and minimal interest in other valuable equipment or medications. Some clinics installed additional security measures, but rural veterinary practices couldn't afford sophisticated systems. The thefts created supply problems for legitimate animal medicine, forcing vets to special order ketamine or substitute other anesthetics that worked less effectively for certain procedures. Underground markets adapted to legitimate ketamine's increasing popularity. Darknet vendors began advertising pharmaceutical-grade ketamine, diverted from medical supplies, commanding premium prices compared to illicitly manufactured product. Chemical analysis confirmed that much of this material was genuine pharmaceutical ketamine, suggesting organized diversion from supply chains rather than basement synthesis. The DA traced some diversion to corrupt employees at pharmaceutical distributors who would falsify inventory records and sell stolen product through encrypted channels. The cultural narrative became impossibly confused. Ketamine was therapeutic medicine, party drug, potential weapon, consciousness exploration tool, and addictive substance simultaneously. Different communities understood it through completely incompatible frameworks. Psychiatrists saw a rapid-acting antidepressant, ravers saw a dissociative high, addiction specialists saw an emerging epidemic, spiritual seekers saw a shortcut to ego death, and law enforcement saw a public safety threat. These perspectives weren't reconcilable because they described genuinely different uses of the same molecule. Social media amplified the confusion by creating echo chambers where each community reinforced its own interpretation. Instagram wellness culture promoted ketamine therapy as enlightened self-care while ignoring addiction risks. Reddit's drug communities shared recreational usage tips and sourcing information. Twitter saw daily arguments between psychiatric advocates praising ketamine's effectiveness and skeptics warning about premature adoption. Facebook groups for ketamine therapy patients became simultaneously support networks for legitimate medical users and enabling communities for addicted individuals in denial. The schizophrenic cultural status created impossible situations for medical practitioners trying to navigate multiple conflicting demands. Prescribed too conservatively and patients suffered unnecessarily while seeking treatment elsewhere. Prescribed too liberally and contribute to an addiction epidemic. Every clinical decision existed in a context where legitimate therapy and enablement were separated by judgment calls with no clear guidelines. Doctors who genuinely wanted to help patients found themselves operating in a regulatory and cultural void where right action was impossible to determine. Media coverage swung wildly between celebration and condemnation, often within the same publication. A magazine would run a feature story about ketamine's revolutionary potential in January, then publish an exposé about addiction cases in March, creating whiplash for readers trying to understand whether the drug represented hope or danger. The truth, that it represented both simultaneously, was too nuanced for mainstream journalism's narrative requirements. Stories needed heroes or villains, breakthroughs or catastrophes, not complex substances with context-dependent effects. The psychedelic therapy movement's co-option of ketamine created strategic problems for more careful advocates. Serious researchers studying psilocybin and MDMA wanted to distance their work from the ketamine chaos, emphasizing that their trials followed rigorous protocols with careful patient selection and extensive therapeutic support. But the public and policymakers increasingly lumped all consciousness-altering drugs together, assuming that MDMA therapy would inevitably follow ketamine's trajectory from controlled research to widespread prescribing to addiction epidemic. The association damaged credibility that psychedelic researchers had spent years building. Conservative opposition to ketamine crystallized around concerns about normalizing drug use through medical legitimization. Critics argued that psychiatric approval of ketamine was the thin edge of a wedge that would eventually normalize cocaine, methamphetamine, and other currently illicit substances through reframing as treatment. The slippery slope argument had historical precedent. Prescription opioids had indeed evolved into a catastrophic epidemic after medical normalization. Whether ketamine followed that pattern or represented genuinely different pharmacology remained unknown, but the comparison was politically potent regardless of medical accuracy. Religious communities grappled with ketamine's consciousness, altering effects from theological perspectives. Some Christian groups condemned any substance that induced dissociative states as opening doorways to demonic influence or spiritual deception. Others embraced ketamine therapy as compatible with faith, arguing that God could work through medicine and that alleviating depression was righteous regardless of mechanism. Buddhist communities had their own debates about whether chemically induced ego dissolution aligned with or contradicted meditation practices aimed at similar states through disciplined awareness rather than pharmacological shortcuts. The insurance industry became an unexpected battleground in the culture war. Some insurers began covering ketamine treatment, recognizing it as evidence-based care for treatment-resistant depression. Others explicitly excluded it, citing concerns about abuse potential and lack of long-term safety data. The decisions seemed arbitrary, creating situations where identical patients received vastly different coverage based on which employer they worked for. The economic reality was stark. Coverage determined access, and access was being distributed based on insurance company risk assessments rather than medical need. Patient advocacy groups found themselves in paradoxical positions. Organizations fighting for mental health treatment access logically supported ketamine availability as an option for desperate patients. But these same groups received reports from members who'd developed addictions, suffered bladder damage, or lost thousands of dollars to questionable clinics. Advocating for both access and regulation simultaneously required rhetorical gymnastics. Yes, ketamine should be available, but only through responsible providers with proper oversight, which didn't exist and nobody was funding. The philosophical question underlying all debates was whether consciousness itself should be pharmacologically manipulable for mood regulation. Ketamine worked by forcibly dissociating awareness from normal processing, essentially breaking consciousness temporarily to allow neural rewiring. This raised questions about the nature of self the ethics of chemically altering subjective experience, and whether psychiatric treatment should aim to change how brains process reality. Traditional antidepressants claim to restore normal function. Ketamine admitted it was fundamentally changing how consciousness operated, at least temporarily. Some bioethicists argued that ketamine therapy represented a dangerous step toward medicalization of human experience. If doctors could prescribe dissociation from reality as depression treatment, what prevented prescription of consciousness alteration for other forms of suffering, grief, existential anxiety, boredom? The boundary between legitimate medical treatment and enhancement became philosophically unstable. Was ketamine treating disease or providing chemical escape from the inherent difficulties of human existence? The answer mattered ethically and legally, but nobody could provide it definitively. Libertarian perspectives added another dimension to the debate. If adults wanted to use ketamine for any reason, therapeutic, recreational, spiritual, why should government restrict access through prescription requirements? The counter-argument emphasized that ketamine's addiction potential and physical harms justified regulation, but libertarians rejected paternalistic protection in favor of individual liberty and personal responsibility. The ideology aligned strangely with both psychiatric advocates wanting treatment access and recreational users wanting decriminalization, creating unexpected political coalitions. By 2023, ketamine existed at the intersection of every major cultural conflict in American society: individual liberty versus collective safety, pharmaceutical profit versus patient welfare, traditional medicine versus alternative healing, drug prohibition versus harm reduction, religious values versus secular science, and the fundamental question of whether consciousness should be chemically malleable for purposes beyond treating clear pathology. Each faction projected their broader ideological commitments onto a dissociative anesthetic, making rational policy formation impossible. The drug had transcended its molecular identity to become a symbol. Progressives saw it representing medical innovation and breaking mental health stigma. Conservatives saw government failure to regulate dangerous substances and elite privilege to use drugs legally while others were incarcerated. Libertarians saw it demonstrating that drug prohibition was arbitrary and unenforceable. Medical professionals saw it revealing psychiatry's desperation and pharmaceutical industry's corruption. Each interpretation contained partial truth, and none captured ketamine's full reality. The culture war guaranteed that reasonable regulation would remain impossible. Any policy proposed would be attacked from multiple directions by groups with incompatible goals. Tighter restrictions would harm legitimate patients while driving use underground. Looser regulations would enable addiction while legitimizing recreational use. The status quo of minimal oversight satisfied nobody, but changing it required political consensus that couldn't exist when the drug symbolized everything different factions fought about regarding medicine, consciousness, freedom, and the state's role in protecting citizens from themselves. Ketamine had become bigger than ketamine, a molecular proxy for unresolved societal conflicts about suffering, treatment, addiction, consciousness, and the boundaries of medical practice. The arguments weren't really about a dissociative anesthetic's proper use, but about fundamentally different visions of human flourishing, medical authority, and individual autonomy. These conflicts wouldn't be resolved through research or regulation, because the disagreements were philosophical and political, rather than empirical. The fighting continued while patients and users navigated the chaos, making life or death decisions about treatment and risk based on incomplete information and incompatible advice from trusted sources. Some found relief and recovery, others found addiction and disability. Most found themselves somewhere between salvation and destruction. Using a molecule that nobody fully understood in a medical context nobody could adequately regulate, hoping they were on the right side of a line that kept moving. The long-term outcome data began arriving in 2024, and the results were more complicated than anyone wanted to admit. Research teams tracking patients who'd started ketamine treatment 5 years earlier published findings that challenge both enthusiastic advocates and outright critics. Approximately 40% of patients maintained significant improvement with continued periodic treatment, showing sustained reductions in depression that persisted as long as they received maintenance infusions every few weeks. These patients had essentially found a viable long-term management strategy, treating ketamine like insulin for diabetes, ongoing medication for a chronic condition that would likely require lifelong treatment. Another 30% showed initial dramatic improvement that gradually diminished over time despite increasing frequency or dosing. Their brains seemed to develop tolerance or adaptation to ketamine's effects, requiring more drug to achieve less benefit. Many in this group eventually discontinued treatment, either voluntarily when it stopped working, or involuntarily when they developed complications like bladder damage. They'd gotten temporary relief but not lasting remission, leaving them back where they started or worse after years of ketamine exposure. The remaining 30% included patients who'd developed addiction, those who'd never responded adequately to begin with, and people who'd stopped treatment for various reasons: side effects, cost, life circumstances, or simple exhaustion with the medical system. This final third represented ketamine's failures, though disentangling treatment failure from inappropriate patient selection or inadequate therapeutic support proved impossible from observational data. Some patients in this group had been set up to fail by clinics that provided ketamine without concurrent therapy, or by their own unrealistic expectations that the drug would cure rather than manage their conditions. The data revealed something disturbing that researchers had suspected but couldn't prove earlier. Ketamine's antidepressant effects often diminished over time even with consistent dosing. The first infusion produced dramatic improvement. The 10th infusion helped noticeably. The 50th infusion did something, but patients struggled to articulate exactly what. The phenomenon suggested that the rapid neuroplastic changes that made ketamine effective initially couldn't be sustained indefinitely. Eventually, the brain reached some equilibrium where additional ketamine exposure produced diminishing returns. This created an impossible clinical dilemma. Patients whose depression improved dramatically on ketamine faced a choice: continue treatment indefinitely, despite decreasing effectiveness and accumulating risks, or stop and watch their depression return. Neither option was acceptable, but those were the only options available. Some psychiatrists began cycling patients on and off ketamine, hoping that breaks would reset tolerance and restore effectiveness. The approach showed mixed results. Some patients maintained benefits through strategic cycling. Others relapsed during off periods and never fully responded when treatment resumed. Brain imaging studies on long-term ketamine users produced concerning findings. Repeated exposure appeared to cause structural changes beyond the therapeutic neuroplasticity that justified treatment. White matter integrity decreased in some brain regions, suggesting that chronic ketamine might damage the insulation around neural connections. Frontal lobe metabolism showed altered patterns that didn't normalize during treatment breaks. The changes weren't dramatic enough to cause obvious cognitive impairment in most patients, but they were measurable and potentially irreversible. Medicine was learning in real time that chronic ketamine exposure reshaped brains in ways nobody had predicted and couldn't yet fully interpret. The bladder complications became impossible to ignore as more data accumulated. Estimates suggested that 20–30% of chronic ketamine users developed some degree of bladder damage, ranging from mild irritation to severe dysfunction requiring surgery. The risk correlated with total cumulative dose rather than treatment duration, meaning patients could develop problems after months of high-dose use or years of lower doses. No safe threshold existed. Every exposure contributed to bladder toxicity, making the damage essentially inevitable for long-term users. The medical community was slowly realizing it had prescribed a drug that predictably damaged organs in a substantial minority of patients. Urologists developed specialized treatment protocols for ketamine bladder, including bladder distension procedures, instillation of protective compounds, and eventually surgical interventions for severe cases. Some patients required complete bladder removal and reconstruction, using intestinal tissue to create a new reservoir, a radical surgery with permanent consequences. The operations improved urinary function, but often left patients with chronic pain, frequent infections, and need for lifelong medical management. A drug prescribed to treat depression had led them to permanent disability requiring major surgery. The psychiatric community slowly confronted the reality that ketamine wasn't a cure for depression, but a powerful temporary intervention with significant long-term costs. This didn't make the drug valueless. Many interventions in medicine managed rather than cured chronic conditions. But the early enthusiasm had promised something close to miraculous permanent remission, and that promise hadn't materialized for most patients. Ketamine worked, sometimes dramatically, but it worked temporarily and at a cost that accumulated with every treatment. Insurance companies began restricting coverage as long-term cost projections emerged. A patient requiring bi-weekly ketamine infusions indefinitely would cost insurers $20,000 to $40,000 annually, just for the ketamine treatment, not including other psychiatric care or treatment of ketamine-related complications. Multiply that by tens of thousands of patients and the financial burden became unsustainable. Insurers started implementing lifetime maximum treatments or requiring failures of multiple other interventions first, essentially rationing care based on cost rather than clinical need. The rationing created predictable inequities. Wealthy patients continued receiving maintenance ketamine indefinitely because they paid cash. Middle-class patients hit insurance caps and either paid out of pocket or stopped treatment. Poor patients never accessed ketamine at all, unless they qualified for research studies or found the rare clinic offering sliding scale fees. The two-tier medical system that had characterized ketamine treatment from the beginning became even more entrenched as financial realities forced explicit choices about who deserved access to effective but expensive treatment. Researchers began exploring alternatives that might provide ketamine's benefits without its risks. Some focused on specific metabolites, the compounds ketamine broke down into in the body, that showed antidepressant properties without producing dissociation or bladder toxicity. Others investigated different NMDA antagonists with better safety profiles. A few teams explored whether the dissociative experience itself was necessary for therapeutic effects, or if the neuroplasticity could be triggered without consciousness alteration. None of these approaches had produced viable treatments by 2025, but they represented acknowledgement that ketamine itself was an imperfect solution requiring improvement. The pharmaceutical industry saw the limitations as opportunity rather than problem. Multiple companies initiated development of next-generation rapid-acting antidepressants that mimicked ketamine's mechanism without its downsides. The drugs would take years to develop and test, require hundreds of millions in research investment, and ultimately command premium prices if approved. Meanwhile, patients needed treatment now, and ketamine remained the only available option for rapid antidepressant effects, despite its growing list of complications and limitations. Some psychiatrists began questioning whether the entire ketamine treatment model had been misconceived from the start. Perhaps dissociative anesthetics weren't appropriate for chronic psychiatric treatment at all. Maybe the drug's proper role was as a crisis intervention, something used once or a few times to provide rapid relief during suicidal emergencies while other treatments took effect, not as maintenance therapy requiring years of repeated exposure. This more conservative approach would maximize benefit while minimizing cumulative risks, but it required abandoning the vision of ketamine as ongoing treatment for chronic depression. The shift toward limited use faced resistance from multiple directions. Patients who'd maintained remission on regular ketamine didn't want their treatment taken away based on theoretical risks. Clinics generating substantial revenue from maintenance infusions had no financial incentive to restrict treatment. Pharmaceutical companies selling esketamine needed broad chronic use to justify their price points. The stakeholders with the most influence all benefited from expanded rather than limited ketamine use, creating structural barriers to implementing more cautious approaches. Academic researchers publishing about ketamine's long-term risks found themselves attacked by patient advocates who accused them of trying to restrict access to life-saving treatment. The advocates weren't entirely wrong. Emphasizing risks without acknowledging benefits could indeed lead to tighter restrictions that harmed patients. But ignoring accumulating evidence of complications served nobody except the commercial interests profiting from unrestricted prescribing. The debate became polarized and personal, with researchers accused of callousness and advocates accused of enabling addiction. The middle ground of acknowledging both genuine benefits and genuine harms collapsed under the weight of opposing maximalist positions. Meanwhile, the recreational ketamine market continued growing independently of medical developments. Young adults in major cities discovered the drug through party culture, unaware of its psychiatric applications. Club bathrooms became informal ketamine lounges where strangers shared bumps and compared dissociative experiences. The recreational use remained culturally separate from medical treatment, despite using the same substance. Party users looked down on medical patients as over-medicalized, while medical patients viewed recreational users as trivializing a serious treatment. The two populations rarely acknowledged they were part of the same phenomenon. Emergency departments tracked increasing ketamine-related presentations that fell into distinct categories. Medical patients came in with bladder complications or seeking help with addiction. Recreational users arrived with injuries from falling while dissociated, bad reactions from contaminated product, or psychological distress from overwhelming experiences. A smaller group consisted of sexual assault victims who'd been drugged involuntarily. The clinical presentations were so different that ER physicians often didn't connect them as manifestations of the same drug, treating each as separate problems rather than facets of ketamine's expanding footprint in society. Law enforcement struggled to address ketamine's multiple roles simultaneously. Prosecuting recreational possession seemed increasingly pointless when the drug was legally prescribed to thousands of medical patients. But ignoring illicit use enabled trafficking networks that also supplied other dangerous substances. Some jurisdictions essentially decriminalized personal possession while targeting dealers and manufacturers. Others maintained strict enforcement that caught legitimate patients alongside recreational users. The inconsistent approaches created a patchwork where ketamine's legal status depended more on geography and law enforcement priorities than rational policy. The medical literature continued growing, with hundreds of studies published annually examining different aspects of ketamine treatment. Papers documented effectiveness in specific depression subtypes, optimal dosing protocols, combination approaches with therapy or other medications, neuroimaging correlates of response, and risk factors for complications. The research was rigorous and valuable, but also revealed how much remained unknown. After more than 20 years of psychiatric ketamine research and a decade of widespread clinical use, fundamental questions about mechanism, safety, and optimal application were still unanswered. Patient communities online evolved their own collective wisdom based on thousands of individual experiences. They identified patterns that formal research hadn't documented. Certain depression types responded better. Specific dietary or lifestyle factors influenced effectiveness. Some patients needed higher or lower doses than standard protocols recommended. This crowdsourced knowledge was anecdotal and uncontrolled, but often more practically useful than published research because it reflected the messy reality of actual treatment, rather than the controlled conditions of clinical trials. By 2025, ketamine had been a mainstream psychiatric treatment for roughly a decade. The early excitement had faded into something more nuanced. Recognition that the drug helped many patients, but rarely delivered the miraculous permanent cures initially promised. The treatment landscape had matured from Wild West chaos towards something resembling organised medical practice, though massive gaps in regulation and quality remained. Ketamine had secured its place in the psychiatric toolkit, while also accumulating a growing ledger of complications, disappointments, and unintended consequences. The molecule existed in a permanent state of paradox. It was simultaneously breakthrough treatment and problematic drug, lifesaver and addiction risk, evidence of medical progress and indictment of psychiatric desperation. The paradox couldn't be resolved because all aspects were genuinely true, depending on patient, context, and outcomes. Ketamine helped people and harmed people, sometimes the same people, sometimes sequentially, sometimes simultaneously. The unfinished experiment continued playing out in real time across hundreds of thousands of patients worldwide. Each person receiving ketamine treatment represented a data point in an ongoing trial with no planned endpoint. Success and failure, benefit and harm, treatment and addiction, all accumulated in the collective experience of a medical intervention that had bypassed traditional gatekeeping to become widely available before anyone truly understood what it did or should do. Nobody knew how ketamine's story would ultimately end because the story was still being written. Future researchers might look back on the 2010s and 2020s as either a revolutionary period when psychiatry finally broke free from inadequate treatments, or as a cautionary tale about premature adoption of powerful drugs without adequate safety infrastructure. The truth would probably be both, another paradox added to ketamine's collection. The patients and users navigating this uncertainty couldn't wait for historical perspective. They made decisions daily about whether to start, continue, or stop ketamine treatment based on incomplete information and conflicting advice. Some chose right for their circumstances and thrived. Others chose poorly and suffered. Most existed in the ambiguous middle, experiencing partial benefits alongside partial costs, unsure whether they'd made the right decision, and unable to know what alternative paths might have offered. Ketamine had taught medicine an uncomfortable lesson. Sometimes a drug works without being safe, helps without being sustainable, and gets widely adopted before anyone understands whether the adoption was wise. The lesson came too late to prevent the experiment, but perhaps early enough to inform future decisions about the next promising molecule that offered hope to desperate people before science had time to fully understand what it promised or threatened. The experiment continued. The outcomes remained uncertain. The costs kept accumulating alongside the benefits, and millions of people worldwide lived inside the uncertainty, hoping they'd chosen right when they decided to let a dissociative anesthetic reshape their consciousness in pursuit of something resembling mental health.